Hello, good afternoon, good morning, a very warm welcome to everyone joining us today. My name is Ethel Makila, the Director for Communications, Advocacy and Policy at IAVI, based in Nairobi, Kenya. And I have the pleasure of moderating today's webinar. It's the fourth in a series of conversations about pathways to eliminate malaria in Africa. And these webinars are hosted by the Health Tech Platform, which is an initiative of AFIDEP. And I believe Adudo is going to post the details and the links to more information in the chat. So far, these conversations have covered what it takes to eliminate malaria from Africa, what the threats are to achieving this goal by 2030, and how to sustainably finance these efforts. And today we are going to talk about innovation and emerging technologies. It's a very exciting conversation coming up. We have a keynote speaker, and this will be followed by a discussion with a panel of experts. So without any further ado, let's get straight into the keynote talk. And it's a talk about advancing innovation of emerging tools and technologies for malaria elimination. This talk will be delivered by Dr. Fredros Okumu. And Dr. Fredros is the Director for Science at Ifakara Health Institute. So, Dr. Fredros, take it away.
Thank you, Edsel. A very good morning to everybody. Edsel, can you confirm that you can hear me?
Yes, Dr. Fredros, we can hear you.
Excellent. So, first of all, I have to say that I am going to disappoint you a little bit. I am aware that most people have come to listen to a talk about technologies. But I'm also aware that in the panel discussion, there will be several people talking about specific technologies. So what I'm going to do instead is to speak broadly about how we can transform malaria control in Africa. And then towards the end, discuss how the new innovations or the technologies fit into this framework. I have 20 minutes to do this, and I'm going to share my slides right now. Shall we begin?
Yes, your slides are visible. You are
Excellent.
audible.
So transforming malaria control in Africa. I guess what's important, first of all, to realize, often when people ask us, why do we still have so much malaria in Africa? People default to comments such as insecticide resistance and drug resistance. And as much as I agree with that, I think it's important to realize that the challenge we are facing is much broader than that. And that it's got several facets, all of which are important and we must tackle. We're talking here about weak health systems, poor data quality, suboptimal compliance. We're talking about broader challenges with epidemiology and poverty, imperfect interventions. And then, of course, you have these issues of drug resistance, et cetera, et cetera. On the other hand, we also have challenges with financing, regulatory delays, or incapacities. And Africa being the only continent where population is growing means that even if we reduce malaria, we actually always have more of the problem to deal with. So for this reason, I'm going to present a rather four-part transformational agenda here. The first of which is that we have to transform our own perception about the problem, and then transform what the target is, and then transform our understanding of what the risk factors are. And lastly, how do we transform, or how do we input transformative technologies about that? So to begin with, the perception about the problem. So of course, we go to WHO and they mention these numbers. And for most of us, this is really just statistics. But for individual families, it's not that much of a statistic. It's real numbers. If you think about it, malaria is going to kill approximately 1,700 people today. It killed approximately the same number yesterday. And even though we hear of numbers such as, 249 cases, there's a realization there that these are variations. So, for example, the number of deaths could go as high as 750,000. Yesterday, my colleagues from Mozambique published an article where they represented data of a baseline survey of a project they intend to do there on the use of ivermectin to control malaria. This was a baseline survey, but one of the graphs that they had in that was this expression or this representation of the risk of dying in different age groups. And if you look at this, this is very representative of what happens in Africa, actually. And you see the riskiest time to be alive in many of these communities is when you are below 5 years old. Now, if you survive that age group, your chances of dying go down dramatically. What we have to do then is how do we transform? How do we help kids skip that? So, in my opinion, the idea really is not just to go to zero malaria as the target. Our target instead should be, broadly speaking, how do we make malaria not a public health concern? Even if we go to zero today, it probably won't mean much unless our communities are able to deal with this problem. So it's a much broader than just going to zero today and then we don't know what will happen today. So that's number two. The goal is not to go to zero, but really to make malaria not a public health concern. So let's talk now about the risk factors and how we can make some transformations there gradually. Now, of course, like I said in the beginning, you want to do multiple things that together constitute the idea, help you to bring malaria down significantly. And some of these things might not be technology oriented, even though I know people are interested in technology. So number one, of course, we have to gradually address weaknesses in our health systems. Why is this important? Very, very fortunately for malaria control experts, unlike diseases like tuberculosis or HIV, for malaria, we actually have really, really good medicines. And some of the medicines, ACTs, for example, have cure rates almost 100%. 98% cure rate is commonly reported. However, because of the challenges that you have in the health systems, often people either do not go in time or they do not get good diagnostic or do not get the right medication. So overall effectiveness is actually very low. As a result, you have this situation where the highest proportion of deaths of malaria happen in very, very remote areas where health access is very poor. This is not a case where we need a new technology. This is a case where we just need to stop this nonsensical death by ensuring that people have access to this medicine. So this is not a case where you need a new technology, really. You just need to ensure that people have access to the medicines that are now already widely available. So that is the first transformation we have to do. I understand that it's gradual, it cannot be done in one go, but countries must actively invest in empowering and enhancing their health system. The second thing is improving the quality of the data, the availability of the data, and the use of data to guide decisions. Now, WHO has already told us since 2015 that we should incorporate data use as an intervention itself in malaria control. GTS recommends surveillance as itself an intervention. What we do see, however, is most countries do not report the real data. In fact, at the moment, when WHO produces annual reports, they get data from approximately 80 countries, and most of this is suboptimal data. So they have to do a lot of mathematical modeling before they can generate the actual numbers. You have other challenges, such as limited use of information to build new strategies. And I'll give you a few examples. This is a report from, this is an excerpt from the last year's World Malaria Report. And I was saying this earlier, the number that people commonly quote is 627,000 deaths. But if you look at the actual data, you see it's quite a wide range. There's like a 200,000 death variation there. So the true number can be anywhere between 500,000 plus to 750,000. So that big gap is narrowed already. In the past, WHO had much worse data, and so those variations were even higher. Here's another one. So some scientists conducted studies in 22 African countries. They looked at 135 different indicators that countries were reporting. What was very, very sad, unfortunately, was that they found that none of these countries actually met more than 1/6 of the targets that they had in their own strategies. And only 4 countries had lowered, as a result, their subsequent targets in the following strategies. In other words, countries do not necessarily formulate strategies based on their own data. What you find mostly is that people are defaulting to global policy, and they make a policy without necessarily relying on their own data. This is changing, but it's not changing at the right pace. We need to be using data much more, and I think that's itself an important transformation. A related concept here is, of course, now you also have the rise of genomics and mathematical modeling, both of which are important subjects. I think very important for different reasons, but they also, in a way, do not necessarily solve the problem on the ground, and are sometimes seen as incentivizing lack of data collection. So instead of collecting the real data, people are more attracted to studying genomics and mathematical modeling. This is not a criticism of this. This is really just to say we've got to balance by ensuring that we are also gathering the right amount of data. The next thing that we have to do is we have to adopt a more holistic and multisectoral approach, as opposed to just relying on commodities. And by commodities here, I mean imperfect commodities that are often applied imperfectly. At the moment, unfortunately, we're relying a lot on insecticides, nets, and drugs. Now, these things, of course, are important, and they will give us some level of control in the short and medium term. Unfortunately, you have to keep doing it, otherwise the disease goes back on a rebound. Now, as much as bed nets, insecticides, and all that are great, we have to be in parallel investing in something else. And my proposal has been that, of course, we have to use the funding that we have at the moment to accelerate progress with the current interventions, drugs, insecticides, vaccines, diagnostics, do as much as we can in the short and medium term. But while we are doing that, we have to gradually expand to other multisectoral initiatives, expand strengthen our health systems, like I was saying earlier, and after some point, begin to prioritize structural and environmental resilience factors to make sure that these communities do not go back to a malaria situation. While you're doing this, of course, you have to also invest in R&D and capacity building programs with versatility. I can explain this later if there's any question. What is important to realize here, however, is that in the beginning, for most low-income settings, actually for most malaria countries, a lot of this will be financed with money from external sources. What we would love to encourage countries to do is, yes, of course, you can begin this way, but you have to plan so that the future of malaria control in your country is primarily domestic financed. And so that means the proportion of domestic financing must keep increasing. You have to realize that these interventions can give us a lot right now, but they should not be the lasting game plan, because you cannot keep distributing 24 million bed nets every year. It's going to be super expensive, insecticide resistance, costly, etc., etc. The next thing, of course, increase both domestic and international funding for malaria control, and this is very, very important. We see always that the budgets, the targets are never reached. In the last case, for example, we have a target of 7.3 billion. Countries didn't even raise slightly more than 5 billion. So we need a lot more financing to cover that. Some of the estimates that we have seen from WHO suggest that we have some kind of a flat line for the past 10 years, where there's very little increments on annual basis. This is at a time when the commodities that we are using for malaria control are actually going up in pricing. The Global Fund estimation suggests that we have a gap of about 28 billion, about 38 billion dollars. And people have asked, how do we finance this? When you talk to people, some of the innovative suggestions that I consider a little bit transformational that could be considered here include, for example, can we tap into the tourism sector? Can we use tax reliefs or even debt relief, if possible? Infrastructure development financing. A lot of African countries are able to go to China and get $1 billion shillings or so to build a road. Maybe some of the vector control money can be tied into this kind of stuff. The private sector should be brought in, etc., etc. So overall, we're looking at this as something that if we invest properly, we should have a good return on investment, especially because we are protecting the lives of these kids who eventually can become the opinion leaders in the future. The next thing, of course, is to realize that the epidemiology of malaria in Africa is very, very different compared to elsewhere. So often people say, hey, why don't you do what they did in Europe? Why don't you do what they did in America? They already eliminated malaria there. Why are you just copying why don't you just copy what they did? What you've got to realize is that we actually cannot copy what the United States did. We cannot copy what Europe did. And this is a mistake that people make a lot by telling us, oh, so-and-so already did it, why don't you do what they did? Now, the epidemiology of malaria in Africa is very, very different. Now, in addition to that difference, of course, and I will explain what that difference is, then you have additional factors that compound it. So here are some examples. Number one, the malaria-transmitting mosquitoes in Africa are very different. They are mosquitoes that love people. They love to be in the house. The human blood indices are far higher than those of mosquitoes that you find elsewhere in other continents. An African mosquito typically feeds almost exclusively on a human. That's if you talk about the 4 main malaria vectors. This is not true for the malaria vectors you find in Asia or in the south of the Americas. In addition to this, of course, you have the situation of poverty, very poor housing in some settings. Now, even me, sometimes I get scared to see stuff like this because it might be like, oh, Frederick, you're misrepresenting Africa. But the truth is, there are still many, many parts of Africa that have this kind of housing. Now, you compound this with this vectorial capacity that you have disaster. Now, on top of this, now, of course, you have this commonly mentioned challenges. Drug resistance is coming up. Insecticide resistance is everywhere. Pyrethroid resistance is everywhere in Africa. And MRBTs are not necessarily performing as well as they should. You have an awful Stephensi coming in, and then epidemics and so on and so forth. Biological threats. All those compound to create an epidemiological setup in Africa that is actually very, very different than what you have elsewhere. And we have to think differently, therefore, instead of just borrowing the things that were done elsewhere. There are several other challenges that we must also address, and one of which is, of course, political instability, climate change is coming up, and so on and so forth. The next thing we have to do is to improve the technical capabilities and, of course, the leadership of our healthcare program. Often, actually not once, people have said, you know what, good leadership is itself a good vaccine. And there are people who believe today that the failures in malaria control have a lot to do with failures in leadership. In my own country, in Kenya, I see sometimes that the government has dismissed a whole cohort of public health leaders because of either some mismanagement of financing or lack of accountability. You have all these issues, but in addition, you just don't have enough people. A typical national malaria control program in Africa has just less than 10 people. And imagine these people are handling budgets of $200, $300 million from global funds. It's really very small capacity. So you have to build this in NMCPs and in a network of local institutions so that they can work together to create something good. So towards a close here, I have about 6 minutes to finish this. The next thing, the more important thing then is, okay, so we have some interventions already, these main tools, indoor residual spraying, insecticide-treated bed nets, larval source management. Are they adequate? Of course, they are not adequate. But what do we do? Do we replace them? Some people say, let's add something new. Now, I say, of course, it's good to add something new. But perhaps we can also, first of all, optimize these existing techniques and make sure that they're done very well. First of all, we've been told that these existing tools have done very well. Of course, now they have prevented about 2 billion cases of malaria in the past 20 years. About 12 million deaths have been prevented. But they are themselves, the common statement is that these tools are inadequate. Of course, that is true. But I think that the tools themselves are applied imperfectly. And I think here we have a big opportunity to apply them perfectly. Here are a few examples. Indoor residual spraying is perhaps one of our best interventions against malaria. It's proven historically to crush malaria transmission, especially in high transmission settings a lot. Unfortunately, as you can see, the data that we have from WHO suggests that very few people are using IRS right now for many reasons: logistics, costs, safety. Some people just don't want to open their door so you can come in and remove things to spray the house. How do we innovate around this to make sure that IRS can continue to be done in Africa, but safely and at scale? Do we continue doing it the traditional way? Unfortunately, indoor residual spray is today still being done the way it was being done 100 years ago. So here is a big opportunity to innovate that process to make sure that this is something that we can do better. Same with insecticide-treated bed nets. This is a tool that has been fantastic over the years, but unfortunately, because of insecticide resistance, the new forms happen to be much more expensive. You have additional challenges such as they're not staying enough for long enough inside people's homes. They are lasting much less time than they should. We expect them to be there for 3 years. They are lasting only about 1.9 years at best. And then, of course, you have a lot of biting happening outside as well. So we have to transform all that. And in addition, we have to ensure that we have substantial manufacturing of these nets locally in Africa. Because at the moment, unfortunately, most African countries, the tool that they need most, which is bed nets, they actually import it from outside the continent. So those are some of the things that we can do to do that. Level source management as well, very well done in urban areas, but not properly scaled up in rural areas. Can we optimize it to make sure that it is usable in rural areas as well at scale? Maybe using drones, maybe engaging local communities to do proper mapping and so on. And for all these three interventions, one thing that we must do very actively is to ensure that the industry stays engaged. Because as you might not know, or as you might know, a lot of the benefit that we get from vector control at the moment is coming from the agricultural industry. Nearly all the new formats that we've had have come from agricultural companies. They don't make a lot of money in public health. They make much more money in agriculture. So we're very grateful to IVCC for keeping these guys, convincing these guys to stay involved. And I think we have to ensure that they indeed stay involved. I want to move to the last end now. Ethel, I know time is probably gone. And in the last point, I want to express, first of all, the idea that, yes, we recognize that innovation for malaria generally has been very, very slow. Some of our best tools today happen to be variants of the same tools as have been used for nearly 1,000 years. As an example, coartem, ACTs are our best medicines today. It's a variant of artemisinin, which has been used by the Chinese for 2,000 years. Bed nets are our longest vector control tools ever known, and so on and so forth. But fortunately, this is changing. So we start to have these new tools, and I think this is where we look into the panel discussion. You start to have some kind of an engagement of this machinery. If you look at the portfolio now, this is data from WHO, a lot of new tools being tested, from ITNs to partial repellents all across the board. And that's a good thing. One of the most talked about now is targeted sugar beds. This is where we get mosquitoes that seek sugar to kind of get attracted to that, and you can get this sugar, put some toxin in this sugar and kill some of these mosquitoes in addition to what bed nets do. The other one, of course, is malaria vaccines, and someone else will talk about malaria vaccines here. We don't have a perfect vaccine, but we have a historic process. RTSS has already been scaled up. The challenge is that, in the countries that in places where we have moderate to high malaria transmission, which are the areas where WHO has suggested that RTSS should be used. We have 25 million children being born every year. In those, each one of them needs 4 doses of RTSS. We need, meaning 100 million doses of RTSS are necessary. But unfortunately, the capacity that's available for the next 3 years is only 18 million doses. So that is not going to be enough. R21 is hopefully coming soon, and we are all expecting that this will go through WHO evaluation quickly, and maybe then we have an additional RTSS. Of course, this is not a failure of innovation. It's entirely, as you can see, there are nearly 90 malaria vaccines currently being tested in some 150 clinical trials around the world, and we think that there will be at least one other vaccine candidate coming up soon. Monoclonal antibodies, someone will talk about that, so I will skip that. But I want to finish by saying that even if we had these new tools, all these tools, now consider the real situation that we have in Africa, which is where you have very weak health systems, and at the same time, you have very poor economic systems, situation, low-income households, and very poor health systems. Even if you had the best medicine, even if you had the best vaccine, or some of these commodities, they will require a strong health system to deliver them, and they will require that households are not having to choose between feeding their children and buying the medication. So here we need a real transformational tool. You need a tool that can transcend this situation, a tool that can work regardless of poverty, a tool that can work regardless of weak health systems, regardless of war, a tool that can work anywhere. And there, I think that we have an opportunity, a very, very unique opportunity with genetically modified mosquitoes, especially those that use the gene-drive technology. Here, in my opinion, is perhaps the only intervention that can transcend the big challenges that we have with health system and that we have with poverty in Africa. And we are very, very proud of the work that Target Malaria is doing in Africa, but also the work that groups like UCMI are doing, and also the work, of course, that my colleagues at the Ifakara Health Institute and Imperial College and NIMRI Tanzania have done under the Transmission Zero, where recently we created the first transgenic mosquito made in Africa. I think this is going to be an interest point for discussion today, but first of all, I dare say, as my colleague Lena says all the time, we must listen to the communities, to our stakeholders, and decide together with them and do what they best want. I would like to stop here, Heather. Thank you so much for the opportunity, and I look forward to the conversation going forward. Back to you.
Thanks so much for a very insightful talk. You've highlighted the multiple challenges and how we need to shift our paradigm, our perspectives. Maybe we should have a new target of malaria being not a public health concern. Maybe that should be our target. What I found very interesting was or curious, that compared to Asian mosquitoes, for example, that the African mosquitoes love humans, and that is a factor. But you also have highlighted the importance of optimizing the tools that we actually have and accelerating innovations to transcend all these challenges, particularly poverty, and also the diversity or the disparity in access caused by being in remote areas. So I'm really hoping that the panel that we're going to have is going to give us hope on what the innovations are in the pipeline. And at this point, I request the panelists, if possible, to enable your cameras. We have today panelists representing various different innovations. There's Dr. Neville Kisalu, the program advisor in PATH's Center for Vaccine Innovation and Access, Dr. Rose Jalango, the head of National Vaccines and Immunization Program at the Ministry of Health in Kenya, who is also the lead coordinator for the Malaria Vaccine Implementation Program. We have Mr. Alois Urasa, the chairperson for Africa Leaders Malaria Alliance, ALMA, Youth Advisory Council. And lastly, we have Dr. Brian Tarimo, a research scientist at Ifakara Health Institute. So To all the panelists, I basically have the same question, but because of the different innovations you represent, your answer will obviously be different. So my question is, what is the promise of the technology that you are proposing? And how does it complement the current strategies for malaria control and elimination? And of course, we are looking at how we transcend the various challenges, how we transcend that poverty divide, how we transcend the health system's strength. How does the technology you propose, Dr. Kisalo, I'll start with you, monoclonal antibodies. Talk to us about it.
Yeah, thanks, Sita, and thanks to everyone. Let me share my screen. My name is Neville. Can you see my screen?
Yes, we can.
Okay. So I've been working on monoclonal antibodies. So I'm from PAT, an American citizen now, but originally I'm from the Democratic Republic of Congo. When I was a child, I used to suffer maybe twice a month from malaria. And I used to tell my mom, someday if we have a vaccine, I'll be the first one to have it. I didn't know I'll be part of the solution. So I went to UCLA, got my doctorate degree in microbiology, immunology, and molecular genetics, and then came to the NIH. And I've been working with Dr. Sider, where I have developed some of the antibodies I'll be talking today. And then now I'm at PAT, leading the vaccine initiative for malaria and also the correlates of protection. So before talking about this technology, I was thinking to show you how we make these antibodies so you have an idea what's going on in this field and how we make these antibodies. So you need to take them either from people, naive volunteer in the US or Europe, you immunize them with a malaria vaccine, or you can get them also from endemic area people, or you can get them from monkeys, you immunize them. And when you have them, you can select the subject. When you have this subject, you can select the subject based on where they bind on the parasite. And then after that, you can get this antibody, and we use several strategies. You can do probe salt, you can do plasma blood salt, you can do memory B cell culture, or you can do memory B cell immortalization. And this is how we characterize these antibodies. So we do functional study. First, you do in vitro. If you can, for example, targeting the pre-erythrocytic stage of the parasite before they get to the liver. So I can use liver cells and add my antibody and the parasite to see if this antibody can block invasion of the parasites. Or we can also use mice. These are black mice or the human mice. We use the human mice because Plasmodium falciparum cannot infect the normal mice. So you need mice that have human liver so they can establish infection. And then you can assess the efficacy of your antibodies. And also, after that, when we see these antibodies are efficacious in animals or preclinical studies, you can characterize them, where they bind, and what gene sequences they are using. And also you can do structure and biophysical characterization to see the molecular interaction to better understand the mechanisms by which these antibodies work. And then I wanted to show you the in vivo model. We have two in vivo models, as I said. You use the black mice. These Plasmodium falciparum cannot infect these black mice. So we have a strategy. You use a mouse strain of parasite, but expressing a protein from P. falciparum sporozoite, for example, CSP. So what you do, you passively transfer, you inject mice with the antibody, and then you challenge them IV with a syringe with the sporozoite. These are the infectious form of the sporozoite, of the malaria parasite. And then you can use imaging approaches to assess whether they are infected. And that depends on the blue color. The more you have the red color there, the more the liver is infected. So we are assessing the liver burden. Or you can also do natural transmission here, where you treat mice and then you let infected mosquito bite them, and 4 to 12 days you can assess in blood what's going on. And the second mouse model is this one here with human liver. These are human liver mouse. Again, you infuse them with your antibody and then you let infected mosquitoes bite them, and then you can add in the mouse body red blood cells, human red blood cells, so you can establish infection by P falciparum. So we have used all these tools to generate Cis43LS. This is the monoclonal antibody I generated when I was at NIH, and also L9. That's a grad student I have trained in the lab that has developed L9, and both antibodies are in clinical trials, as I will show you shortly. And then when you have them, before you use them in people, you can modify, you can make some modification. So what I'm showing you here, this is a monoclonal antibody, is Y-shaped. This is the variable region and the constant region. So you can introduce mutation in red in the constant region to increase the half-life durability in people. So we did that before we proceeded in human. So now let me go back to your question. So we know that major milestones have already been achieved in malaria vaccine, R&D, and the use of drug for chemoprevention. But the complex drug regimens required to achieve duration of protection can result in adherence issues. So in October 2021, RTSS was the first malaria vaccine WHO recommended for widespread use in moderate to high transmission settings in Africa. And work is ongoing now to develop next generation vaccine and drugs for chemo prevention. Sorry. And both of these interventions face challenges. For example, for RTSS, it only has a moderate efficacy and duration of protection due to the difficulty in maintaining high levels of antibody and T cell to mediate durable protection. And also, there are other factors that may influence vaccine efficacy, which include pre-exposure to malaria, parasite diversity, and age. As with all vaccine, it takes a while and it takes a lot of money to develop a vaccine. So in parallel, work is ongoing now to develop new drugs for malaria chemoprevention, but they are unlikely to be available in the short term. So we believe passive immunization with monoclonal antibodies by direct administration of functional antibodies can potentially complement the limitation of vaccine by providing immediate protection. So the advantages of using MABs include an alternative immune approach independent of the potential factors that limit immunity by vaccination. And for future malaria MABs, they could potentially be used as prophylaxis for several months, providing protection for defined periods of time in population at high risk. And these could be children or pregnant women or immunocompromised people that cannot, for example, if you immunize them, they cannot make this antibody to protect them. And furthermore, the development of MABs with simplified dose regimens, for example, a single administration dose that could potentially circumvent some of the coverage and adherence issues faced by vector control as well as chemoprevention. So, and we know the definition of an antibody. So these are proteins. Antibodies are proteins produced by the immune system. They attach to antigens, and these are foreign substances such as bacteria, viruses, and toxins to remove them from the body. So antibody work in several ways. They can neutralize antibody or inactivate them, or they can kill infected cells, as I'm showing here. So either inactivation, blockade, or neutralization, or they can use Fc-mediated effector functions listed here to kill infected cells. And indeed, antibodies have been shown to block infection, malaria in vivo. What I'm showing you here, this is a mouse that's being bitten by a mosquito. You can see how the mosquito is spitting the saliva with the sporozoites in green. You can see how they're moving in a non-treated mouse. But when you treat a mouse with the antibody, the first 30 seconds, as the mosquito injects the sporozoite, you can see the white sporozoite moving, but by 4 minutes, they are all immobilized. So this was the original ideas that we can use antibodies to block malaria in people. And indeed, this is CIS43, the panel on the right. These are the data that came out late last year, where we showed that you can use CIS43-LS in Mali to block infection in people, compared to the line on top, that's the placebo. People didn't receive the monoclonal antibody. You can see the incidence of infection is high compared to the groups at the bottom. These are the ones that receive antibody. And their CIS43 showed an efficacy of 80 to 90% in the field. So what we know about clinical MABs, we have over 130 clinical antibodies that have been approved globally, and only 11 of these are for infectious disease. And so far, we don't have any single malaria antibody that has been approved. We are still developing them. So, and guidelines for therapeutic MABs exist, but we don't have them for preventive MABs, and they are being developed by the WHO. So let me go quickly. I told you about the current MABs that we have, CIS43, LS, and L9. And also there is another one that is in clinical trial for transmission blocking monoclonal antibody, that TB31F. So how this strategy can complement the existing approaches or tool. So for now, in the current landscape of malaria control, MABs for malaria prevention, antibodies for malaria prevention may offer several advantages over existing tools as standalone products or in combination with existing tools. So the ultimate aim of any malaria antibody is to reduce morbidity and mortality, which can be achieved either directly by preventing blood stage infection or reducing blood stage parasite density, or indirectly by reducing community level transmission. So let me finish, because I put there the priority use case scenario. Who can receive this antibody? Children, for example, their first year of life, they are at risk of severe disease. So children can receive these antibodies, or pregnant women, and that can also protect their babies in their bellies. And we also have other use case scenarios, as I mentioned, immunocompromised people. And then we have other use case scenarios for future consideration. For example, MAB could be used as an alternative to mass drug administration and drug-based prophylaxis for high travelers or workers to prevent outbreak and reintroduction in regions that have already cleared or locally eliminated malaria. So lately, these maps could be used with other malaria control interventions. For example, we published, I think it was 2 years ago, where we combined immunization, active immunization with passive immunization. So what we did, immunize mice with R21, and then when we add monoclonal antibody, we saw that there was a synergistic effect. So these are some of the case scenario, how this new approach of monoclonal antibody can complement the existing one. I think with that, we also have some limitations, the cost of manufacturing, but technology is still evolving. So hopefully in the coming years, we will have approaches to make this antibody quickly. One of them we are thinking maybe come up with an approach you can just inject the antibody DNA and let the body become the factory. And also there is a risk we can have some escape mutants, but so far, for example, for cis43LS or L9, the site we target on the parasite is highly conserved in about 99.9% of field isolates we have evaluated. And with that, thanks for your attention.
Thank you very much, Dr. Kisalo, very much. Lots of information there. And I'm hoping that participants, you may put your questions in the Q&A box or in the chat. Dr. Kisalo, you mentioned the relationship or the complementarity of monoclonal antibodies to immunization. And I think that's a great segue now to Dr. Jalango. What is your take on the promise of immunization, and how does it complement current strategies for malaria control and elimination? Dr. Jalango?
Yeah, thank you very much, Ethel. I'm trying to load my screen.
And just, what do you call it? A disclaimer, we are hoping to have some Q&A at the end of it. So if we could keep it brief, that would be really great.
All right. So, Rose Jalango, I work with the Ministry of Health, National Vaccines and Immunization Program. I've worked in the immunization space for more than 8 years, and malaria vaccine is just one of those vaccines that we do introduce in the country to reduce morbidity and mortality. But today I'm going to reflect on the role of vaccines in complementing the current malaria control strategies towards elimination. The first vaccine to be rolled out was the LTSS malaria vaccine, and I'm sure you've all heard about it. We first had the clinical trials before we rolled it as a pilot implementation program in Kenya, Ghana, and Malawi. So Kenya is one of the countries that did roll out the malaria vaccine. So it's given to children as a 4-dose from any age, from actually 5 months of age, and then the 4th dose is given 12 months after the 3rd dose. So after the pilot implementation that was done in the 3 countries, there was a significant reduction in morbidity and mortality, and also a significant reduction in the severe cases of malaria, and also admissions within the 3 countries that participated in the pilot. So it is after that pilot implementation that the malaria vaccine was scaled up, was actually recommended by WHO that it can be rolled out in other African countries. But the vaccine is rolled out in in areas with moderate to high transmission of malaria. So it works best under those circumstances compared to when it's the transmission is quite low. So in terms of the life saved, so for every 200 children vaccinated, one life is saved. And then there was a more recent trial. The vaccine was provided at the peak of malaria season, and it was actually similar in efficacy to the malaria chemo prevention, in that at least 75% of the malaria cases were prevented. So in terms of our strategy, so for us to eliminate malaria, we require the interruption of local transmission in a particular area. So the RTSS is actually designed to reduce morbidity and mortality. And then there are current vaccines that are under development, the transmission blocking vaccines, which would actually break the life cycle of the parasite by preventing mosquitoes from becoming infected by malaria-causing parasites, which then feed on people. So in terms of the transmission blocking vaccines, this is what is needed to block transmission. So they don't provide a direct protection against infection, but they seek to prevent an infected human from transmitting malaria parasite to a feeding mosquito. So what I'd say from this in terms of the role of malaria vaccine innovation in elimination of malaria is that WHO currently recommends that countries with a high prevalence of malaria can introduce the malaria vaccines in those specific areas to reduce mortality and morbidity. And that is why the countries that are currently introducing the vaccine are introducing it in a sub-national level. So it means that we only focus in those areas that have a high burden of malaria. Then number two, the vaccine is delivered through the EPI infrastructure, and we know that immunization is accessible in most of the areas, even the rural areas, compared to other interventions, for example, like the mosquito nets. So therefore, introducing new vaccines through this platform will ensure that as many children as possible are reached with a life-saving vaccine. However, the vaccines are not used as a standalone. The RTSS that we did roll out, it is used in the context of other interventions. So for example, if the vaccines are being used, the caregivers are still advised to continue sleeping under treated mosquito nets and also continue the IRS. So there's still some hope in that there are new vaccines in the pipeline. So like the current development of transmission blocking vaccines is ongoing, and that would accelerate malaria elimination and eradication. So currently the RTSS is in terms of the doses available to the countries that really need the vaccine is actually quite limited. So we have a high demand and limited supply. So by having more vaccines available means that more children are going to be saved and therefore accelerating towards the goal of elimination. So apart from vaccines, I think we need an integrated approach in terms of how we need to look at elimination. So we also have to look at it in the broad context of other mix of interventions. So whether it's through enhanced surveillance, multi-sectoral approaches, environmental health, I think all these need to be taken into consideration when you are working with vaccines. Thank you, and over.
Thank you so much, Dr. Jalango. I think I'll just scoot over to Alois Urasa, artificial intelligence. Tell us something about that.
Sorry, speaking on mute. Thank you very much, Ethel, for this opportunity. And first of all, I should declare that I'm not an expert in artificial intelligence issues, but a curious person who has been involved in the fight against malaria for now about 5 years now, and still learning about it. And I've been playing around advocacy and being a science trainee and I've been looking around different interventions that can drive us towards zero malaria. And when I was invited to sit on this panel, I chose to discuss about artificial intelligence. That's been one of the areas I've been very curious about recently. And let me share my presentation shortly. So I'll discuss briefly how artificial intelligence has a potential to revolutionize malaria diagnosis and malaria elimination at large. And I know most of us have know that malaria is a really public health problem that we need to bring it, that we need to make it no longer a threat or public health threat, as our keynote speaker, Dr. Fredros, has recommended that our focus should not be zero malaria, but ensuring that it's no longer a public health threat, as it continues to kill people, and ultimately by the end of the day, it will have killed about 1,700 people, based on the estimates from WHO report last year, that it killed over 619,000 people, most of them being children under the age of 5 and pregnant women. So there are several interventions that have been taken in order to ensure that we achieve the goal to zero malaria and ensuring that malaria is no longer a threat. And there are several traditional diagnostic tools that have been used in order to fight against malaria, or to ensure that we track and ensure proper treatment for malaria after proper diagnosis. We have the rapid diagnostic test. We have the microscopy technique, which is considered the golden standard. We have molecular techniques, many other but we could think of what are the challenges of this. And I really like the topic of this webinar, that the issue is not to replace these tools or to replace the interventions that we have been taking to fight malaria, but rather to complement the interventions that are there. And in my perspective, I think main challenges have been around time, reliability of these tools, and their validity. And some different papers have discussed about each, looking at its advantages and disadvantages of these techniques, from microscopic examinations to flow cytometry, biomarkers, and molecular techniques that are being used. And now looking at why we need artificial intelligence to complement these strategies. First of all, artificial intelligence is the theory and development of computer systems that are able to perform tasks that are normally requiring human intelligence. So it's, as by its name, it's an artificial way of dealing with intelligence stuff that human beings could carry by using machines and tools like computer or digital systems. But now AI in malaria diagnosis, looking at artificial intelligence as a potential approach to revolutionize the fight against malaria by enhancing the challenges, as I mentioned, about time, validity, quality, and reliability of the results that we need in order to effectively tackle the burden of malaria. So one of the scientists who is involved in AI published in their paper that the approach could have potential for rapid and high throughput screening for Plasmodium in both non-clinical settings, such as the field surveys, and clinical settings, that is diagnosis to aid case management. And looking at some of the impressive technologies that are coming up to complement existing interventions in the fight against malaria, I discuss what colleagues from Ifakara Health Institute are currently going through. That is the medium-infrared spectroscopy. That's to detect malaria parasites from the DBS, the dried human blood spots, using the medium-infrared spectroscopy and logistic regression analysis. And here I've just kept the approach that the framework that they're using to approach or to find much more information about malaria parasites, but also looking at the vectors using the same technology, the infrared radiation, and utilizing this data to train AI models so that we have real-time data and information of platforms to share best experiences and data related to malaria vectors, but also malaria plasmodium malaria parasites. It's the malaria count done by scientists, CO et al., an image analysis that is best program for accurate determination of parasitemia, and also mobile aware deplaning algorithms, the novel exploration technique, and this is not for diagnosis, but for policy interventions. So we can see that AI is not only focusing on diagnosing, but also supporting other interventions such as policy development and sharing of best practices in the fight against malaria. Another technique that I'll just briefly share with you, it's about the ZZAP Malaria. That is a startup that is collaborating with IBM with an AI-powered mobile application that allows for personalizing malaria elimination interventions in a number of African towns and villages. And this brings us back to community engagement. So AI is also taking us driving us to effective community engagement, ensuring that everyone everywhere has access to this information about malaria, but also have fully engaged or to support the fight against malaria that is that is threatening their own present life and the future. Now, how does this AI tools complement the current strategies? As I mentioned, most of them are looking at reducing the time that we need in order to identify malaria cases, but also identify breeding sites through different prediction models that are being built, but also reducing the cost of fighting against malaria. And this is just similar to what Dr. Neville presented about the monoclonal antibodies, cost reduction. By having these tools, bringing together all the complex information together, pulling together complex information, and utilizing much time in its initial stages to ensure that we don't utilize the same cost over the time or for the long time to gather data and information in the fight against malaria, but also reducing the burden or the need for too much workforce, but also at the same time enhancing or supporting the capacity building for the existing healthcare workforce for the fight against malaria, but also helping to reduce the burden of resource allocation, but also supporting to utilize the limited resources that we have to fight against malaria. So AI could bring together and properly organize how we utilize resources in order to apply effectively the existing interventions, but also improving the quality of the tools that we use, such as microscopy technique. We know that microscopy, for instance, microscopy techniques requires serious expertise in order for it to work effectively. But AI pulls together the expertise from different experts around the world in order to bring much more accurate information about the diagnosis of malaria. But also it's driving us to achieving universal health coverage and enhancing equity in global health. As I can say that artificial intelligence serves as a tool or a vehicle for us to ensure that we reach everyone everywhere, so that we can achieve universal health care for everyone, as it enhances access to quality services, access to information and data, and also it enables other tools that could not be possible to be done in low or developing countries, such as genomics, genomic techniques that could not be easily utilized by scientists in the low and middle income settings, by bringing this data close to them in a simple and sophisticated way. And now, despite being a very significant and important to drive us towards ending malaria burden or making malaria no longer a public health threat, this artificial intelligence approach has its challenges and limitations. One of them could be ethical implications and user perspectives also, and how the community will perceive the use of AI, but how they will be able, also looking at the knowledge of the people, how they could be able to adopt this situation, this technology or these techniques in order to advance access to healthcare. But also it's facing challenges as there is no really financial mechanisms that are put to finance its deployment, but also its development and its deployment. Hence, we need now to ensure that we calm the challenges by addressing another challenge, that is political will and political acceptance of these tools, but ensuring that they're built to be cultural sensitive so that they address real things that will not compromise the culture of the people that we target. To summarize, I can say that artificial intelligence is not a replacement of what we already have on the ground to fight malaria, but rather something that comes to complement or strengthen the approaches that have been existing in order to fight malaria. But now, for them to work effectively, there's a need to ensure that there's effective engagement, financing structures that are really targeted towards enhancing it. But there should be the real intention from the scientists who are developing this to continue improving and making it happen in the communities. Thank you very much, and looking forward to further discussion around this.
Thanks so much, Alois. I think we'll move quickly on to Dr. Brian Tarimo, who will be speaking about gene drives. And I can see the questions coming in the chat. Keep them coming. We're taking note of them, and I hope we'll have a moment to ask the presenters. Over to you, Dr. Tarimo.
Thank you, Ethel. Good morning, good afternoon, everyone. Sorry, I must declare that I did not prepare any slides. I was under the impression we will jump straight into Q&A after the keynote address, but I have a few minutes. I could say some few stuff regarding gene drive. My colleague Fred was talked about earlier that regarding the global cases that we have with regards to malaria, almost over 200 million cases globally, 619,000 deaths, and a bulk of this happens in Africa. You always hear of these things to remind us about the burden that every 2 minutes a child dies of malaria, or malaria kills around 1,700 kids every day. So it is really, really a massive problem that we have on the ground. But this problem is also compounded by the tools that we're also using. They are facing a lot of challenges. There is insecticide resistance we're seeing in the bed nets and the sprays that are being used. Also, there's also issues with regards to the drugs that we've seen resistance developing, hotspots of resistance developing here and there. Also, this is compounded by the health system challenges that we have in Africa, funding concerns that we have not been able to raise enough funding. So even if we had enough, even if we did not have the resistance issue, we do not have enough funding to ensure that we are distributing these interventions effectively to everyone. So with all of these problems, what is that one intervention that can come and almost transcend some of these challenges that we are facing, from insecticide resistance, poor health systems, lack of funding, and so forth? And this is where I'll briefly talk about genetically modified mosquitoes. Well, genetically modified mosquitoes, some call them hybrid mosquitoes. They are mosquitoes that have been genetically modified in such a way that they're impaired. Either they're not able to reproduce, so their ability to reproduce is impaired, or their ability to be able to transmit the parasite is reduced. We know that mosquitoes, they're only vectors. They bite individuals with malaria and then transmit the parasite from one individual to another. So genetic modification can be targeted that it impairs the ability to reproduce. We usually call this population suppression, or it impairs the ability for the mosquito to transmit the parasite, and we call this population replacement. Now, the story has not ended here. Once you've done this modification, you need to ensure that each mosquito from one generation to another has this modification. And this is where a technique called gene drive, which is a natural phenomenon, which ensures that it biases the inheritance. Usually inheritance is 50-50. You're likely to inherit 50% of some of the genes from your father, another 50 from your mother. But what gene drive does, it impairs, it biases this ability, and such that almost all of the offsprings contain the modification that you want to do. So if you have targeted for impaired reproduction, you have almost near 100% of all the offsprings cannot able to reproduce. Or if you have impaired the ability to transmit the parasite, you have near 100% of all the offsprings unable to transmit the parasite. Now, what makes these mosquitoes, there's a big buzz about what's this technology? Why do we think this could transcend some of the current vector control tools that are being used? One is that these genetically modified mosquitoes, they are easily accessible, meaning that they should be able to, you transcend the logistical challenges that exist. I mean, with regards to other control tools that we have, they need to be transported from one area to another. With genetically modified mosquitoes, you can just release these mosquitoes, and then they are able to go out there and do the job for you. Another issue with this genetically modified mosquito is that they are efficient in the sense that you are nearly 100% sure that each offspring from each generation to another is going to have this genetic modification. So once you release, you ensure that the modification is going to spread on from one generation to another. And also they are long lasting. That means with the other current tools that we have, they need to be replenished every now and then. Bed nets get torn, they lose their efficacy and so forth. So every now and then you have to go and get those old bed nets back and put new bed nets in. So these are some of the issues that we see that this current intervention can transcend some of the challenges that we are seeing with other control tools. Not to say that these genetically modified mosquitoes are here to replace these current tools, but we're saying that in addition, as a complement, as a supplement to what is existing, we foresee that there is going to be dramatic malaria control and possibly eventual elimination of this disease. However, with any other technology, there isn't a technology that is 100% free of risks. We understand that there is, but however, the decision on whether technology should be adopted should be basically assessed on its potential benefit vis-a-vis its potential risks. So we advocate for thorough development of frameworks and guidelines that are of international standards to be able to assess this technology. We encourage for institutions, National Biosafety Committee, Institutional Biosafety Committee to have appropriate risk assessment tools and procedures for being able to evaluate this technology. We also advocate for capacity development. Local institutions working in this space should have not only the infrastructures in terms of laboratories and equipment, but also local skilled personnel who are conversant with this technology, they're able to carry out this technology. And also we advocate for community engagement from the get-go. The community has to understand this technology. They have to be involved such that they are aware of what's happening. Lastly, and this is to draw back to a point that my colleague Fredros had addressed earlier, is that he showed a map of the globe, and he showed that the 4 mosquitoes and how the human blood index with these mosquitoes in Africa, meaning that The 4 mosquitoes that are predominant in Africa, they love human blood. That's why you see a higher human blood index compared to other Anopheles mosquitoes from elsewhere. But here I would like to raise a point that there are over 3,500 different species of mosquitoes that are known globally, different mosquito species. We know about 400 different Anopheles species globally, and about 70 out of these 400, they've been proven to transmit malaria. Scientifically, they're able to carry any Plasmodium species from one individual to another. But with the technology, the genetically modified mosquitoes that I've been talking about here is they only target currently targets one of the 4 that are the major vectors of malaria in Africa. So the notion that genetically modified mosquitoes are here to wipe out a species is somehow misleading, because the technology just targets one species out of 3,500 of these species that has been shown to be the major culprit of malaria in our countries and in our continent. With that, I would like to end there, and I'm ready for your questions. Thank you very much.
Thank you so much, Dr. There are a number of questions. You've actually answered one question already, the last one on the species, on the eradication of other species. Maureen, I hope you got your answer from that last statement. So we have spoken about passive immunization, proactive vaccination, particularly of children, rapid diagnosis with artificial intelligence, and genetically modified mosquitoes. So I'm looking at the questions that are already here, and I'd like to first address the first one that came in through to Dr. Okumu. And the question is from Henry, asking about how much are communities being involved in innovations, as you spoke about accelerating innovations and better use, more innovative use of the tools that we already have. And Joe Kawoya also asked you about the use of mosquito repellents, why no one is interested in encouraging them. Maybe you take those 2 questions as we quickly move on through the other questions. Dr. Okumu.
Thank you, Ethel, and thanks to all my colleagues who've given fantastic presentations as well. Now, 2 questions. Number 1, are communities being engaged? I believe yes. I see a lot of engagement around the technologies that I've personally worked on, and I am particularly impressed by the amount and level of engagement that's going on today by the groups working on genetically modified mosquitoes, on gene drives. So I think that's something, of course, it can be improved, but I'm quite glad that people working on different technologies are actively engaging communities. Second question was, why are insect repellents not being taken up? So insect repellents are actually quite widely used, especially in the private sector market. You can buy them, yours, and use them. What we do not have is large-scale use in the same manner as bed nets. And the reason for that is we do not have any data at the moment, field trials to suggest that they would be better than the current practice. There's no trial suggest they would be better than bed nets. So whereas they are good for personal use and they're available in the market in the sense that they prevent mosquito bites, there is no indication that they would be better than what is considered the current tool at the moment in terms of preventing malaria. So there is nothing, nobody is saying that you shouldn't use bed nets. It's just that comparatively, mosquito repellents are not as good as the current best practice, which is bed nets and house spraying. Back to you.
Thank you very much. I think the next question we'll take is a question directed to Alois. And I think I'll enjoin Brian Tarimo because of the nature of the question, and you'll see why. So Sandra Yvonne asks, do you think the potential of these tools outweighs any risks that they may have? And then to Alois as well. So that one, I'm posing it both to Alois and Dr. Tarimo. And the second question now to Alois. The question of AI and the cost implication. So how effective do we expect to have AI when we see that amongst the factors affecting the efficiency of the tools we currently have is poverty? So over to you.
Okay. Yes, thank you very much. And that's a really important question. I'll start with the second question on how will AI be effective when we have seen that factors around economy, poverty, and living conditions impact living conditions, poor data collection, etc., impact on malaria control in Africa. First of all, as I said, AI should be considered as a complement and support to existing malaria elimination efforts, and not like an approach that is coming in silo. It comes to complement the strategies that are in place. And there's a potential of AI, as I mentioned, from helping with data analysis, but also sharing of data, and much more effective way of analyzing and sharing data among the malaria community, and also will help to understand that the complex dynamics that exist within in the fight against malaria, but also enhance early detection, because many people face challenges with late detection of these malaria cases or emergence of new species. So AI works to complement these strategies and enhance that timely detection of emergence of new species, as I said, and also early detection of patients, for example, through the automated image analysis. So instead of going to the hospital and waiting for a turnaround of 1 hour for an expert or laboratory expert to tell you how many parasites you carry, then AI will minimize that turnaround time and make it less than, some of them are even using only 2 minutes to detect. It's just like how the imaging system have worked for radiology with the detection of cancer detection of fractures and stuff. And another way that it's going to complement is through the targeted interventions. As I said, it will help with allocation of resources. So if data is shared effectively on these platforms and well harmonized through these AI platforms, then it's going to ensure that these AI algorithms will really help with detecting areas with higher risk, so that resources are effectively allocated, as we are minimizing the cost, also else solving the problem of economic challenge that we have in the fight against malaria. And another reason is improve the surveillance. AI comes with an advantage to improve the surveillance systems that is there in place, and collecting much diverse data sources. And this answers the question of poor data collection. So AI can enhance effective collection of data and getting diverse data sources, but also aid the decision making system by ensuring that decisions are made appropriately, hence addressing the areas which need the interventions most. So I think AI can really revolutionize and help to address these challenges from economic perspectives, poverty, and poor data collection as addressed. When it comes to the question of risk, maybe I should pause and let my senior, Dr. Brian, to respond first. Thank you.
Yeah, I'd actually like Dr. Brian Tarimo to respond, because there are multiple questions. Despite your assurance, Dr. Tarimo, there are multiple questions concerning the safety to the ecology, to the ecosystems. What risks do we have from altering the genetic makeup of mosquitoes? Yes, what risk is posed by the potential of invasive species? So over to you.
Okay, thank you very much. So to start with, do these all of these technologies, do they outweigh the benefit? So if you look at it from the other perspective, from the other side, so you have every day you have 1,700 deaths. And if you have a technology that has by all measures shown that it could reduce this tremendously, I think by all means that technology should be adopted. However, as I've said, there isn't a technology that is 100% free of risks. So there needs to be thorough evaluation, thorough risk assessment process to ensure that this technology, once it's been deployed, has minimum risk as possible, and it's able to bring the intended benefit to the population and hence result to malaria control and elimination. Therefore, if you look at the different groups globally that are working on gene drive, is that or genetically modified mosquitoes with gene drives, there is that thought there might be an issue, a biodiversity issue. So there are different groups looking at how, if you remove larvae from the population, for example, mosquito larvae, is there any other organism out there that will be deprived of its primary source of food? And that means you're removing Anopheles larvae, therefore you are also removing that organism as well. So there are studies, concomitant studies that are going on to look at these different issues. Mosquitoes preys of any other organism in the ecosystem. Therefore, if you remove these organisms or these mosquitoes, therefore you are depriving these other organisms of their natural food source. So there are studies that are ongoing. So far, with works that have been done in larvae, we are not seeing any of that. And also, two other points to note here is that the gene drive stuff that we are talking about here only targets one type of mosquitoes, only one species of mosquito. So we are not, even if it gets deployed to the field, we are not saying that we're going to remove every other mosquito from the ecosystem. That is one. Two, all the work that is currently happening with gene drive, it's still in the laboratory phase. We do not foresee deployment of this technology maybe in the next 5 to 7 years, because all of these other, as we said, these risk assessment studies, biodiversity studies, they have to be undertaken and give us confidence that what we are working on or what we are proposing to deploy has minimum risk as possible and has the potential to bring as much benefit as we intended or as we are seeing it currently in the laboratory phases. Thank you.
Wow, thank you so much. Would you believe it that we've come to the end of our time together? I'll just wrap it up and probably hand over back to Pauline Soy. But briefly, this has been an exciting conversation. There are still questions coming in, unfortunately. We don't have much more time for that. But Pauline, would I be correct in saying that AFIDEP is able to provide links to additional resources and perhaps look at the questions that have remained unanswered in the chat and see how these can be packaged and responded to for all participants in your follow-up conversation? Pauline?
Yes, you're very right there.
Yes, thanks. So everyone, you got that. There are more questions that are coming in, and Pauline and the team will do their best to respond, to have the experts respond to them. So over to you, Pauline, to tell us about the next steps.
Oh, thank you so much, Ethel. Thank you so much to the panelists, to the keynote speaker. That was really engaging conversation. It's great to know that there are many questions. It's through questions that we find answers, and unfortunately, time is not on our side. As Ethel mentioned at the beginning of the webinar, that this is the 4th webinar we have on the End Malaria Series. The series was launched on the 25th of April. That was World Malaria Day. We've come so far. We've looked at priorities to eliminating malaria. We've looked at threats. On the second webinar, we've looked at investments and funding for malaria intervention. And now we had just had this interesting talk on emerging technologies that could complement current strategies. And the fifth webinar will look at, the fifth is the final webinar in the series. On June 20th, we'll look at research and capacity on malaria control tools, both existing tools and emerging health technologies. And so we hope that we'll still have you in the next webinar. Please note the date is on June 20th, but we'll also share all these resources, and this recording will also be shared. We'll also share the presentations that we had today in a follow-up email. So thank you so much. I know we were supposed to have a survey, a link to survey, but we'll also share this post webinar. Yes, the link is on chat. We'll hold on for 5 minutes for you to just fill the survey. It helps us in, your feedback will help us in tailoring other webinars and see really what is the most important thing that you'd want to see in future webinars. And so we really hope that you enjoyed this. It was informative, at least from my end. I hope it was informative from your end also. And hold on for 5 minutes, 3 minutes to fill in the form.
Yes, please. We appreciate your having stayed with us 6 minutes past the time that we had promised. Take 2 more minutes to fill in the form. And Pauline, there's one more question. I'm sure you'll be able to share the links to the other recordings so that we can have a nice transition from what was talked about before to what we will finally have in the next conversation. I'll be there. I hope you'll be there for the 5th one.
All right. Thank you so much.
Okay, so have you had your opportunity for the survey to be filled? How is it going? Perfect. Thank you so much, everyone, for having made the time. Remember, the next webinar is on the 20th of June, the final in the series. We hope to see you there. Thank you and bye-bye.
Bye.
Bye-bye, everybody. Thank you.
Bye-bye.